So really, depression feels like sadness, sluggishness. Just go to your emergency room. Go to your nearest emergency room. Emergency rooms are not just for medical emergencies. I mean, saving your life is priority. And
This is a
then
great advice.
I really think that TMS has been like a holy grail for me when I have patients who are highly depressed or unmotivated. TMS will start the engine. TMS doesn't really have a lot of side effects, if any. Whereas some medication can have significant side effects, including like gastrointestinal side effects, and obviously changing your brain's biochemistry.
Hi, everybody. Welcome to new episode of TMS First Choice. As you know, we're going to continue to bring mental health experts and address many issues which TMS also can address. Today, we have Dr. Jelena Djurovic. She's a licensed clinical psychologist. I really hope that she's going to help us understand how talk therapy can be connected with TMS therapy and how patients can benefit from having both of them. Welcome, Jelena.
Thank you. Hi.
For starters, can you please explain us how we can recognize the symptoms of depression and anxiety, but in a way that our patients or other people can understand that?
Sure, absolutely. So basically, of course, both depression and anxiety are conditions that are unpleasant to us, right? Something that we don't want to experience. And there are certain criteria that we as clinicians use to recognize these. And we use obviously the DSM, but like you said, you would like for the patients to understand this. So really, depression feels like sadness, sluggishness, no desire to do anything, loss of interest into the things that you used to enjoy, crying more often than usual, things like that, sleeping more or less, losing or gaining weight without trying. Those kinds of things.
Do they usually compound to each other, or it's actually unique to every person?
Well, the set of symptoms can look pretty unique to every person. What you do need to have is either sadness or loss of interest or anhedonia to even qualify. So if you don't have one of those two, then you don't have depression, and then you can have a combination of I believe 5 or 6 other criteria of the ones that I mentioned to have a diagnosis of clinical depression, right?
Okay. One of the definitions which I was able to find, and I really like it because it's very self-explanatory, is depression is the state when you basically stop enjoying things which you enjoyed before it.
Yes.
I believe that's a pretty good one.
That is a good one, yeah.
Okay, well, how to find the adequate help?
Well, just like every person is unique and every person's symptoms are unique, so too the kind of help that they need is unique, right? Different for everybody. But because we know that there are some biological and neurological processes that are involved in both depression and anxiety, then we can know that by addressing these processes, we can be sure to expect some positive change, right? And there are multiple ways in which we can address these, but mostly we do talk therapy, right? Combination with a medication and then some other additional treatments, or which could be a first line of treatment, such as the Transcranial Magnetic Stimulation, or TMS.
Okay, so usually what I'm seeing is that PCP is the first station, and the second one it's psychiatrist, and then probably psychologist. So just to explain, psychiatrist is the one who is prescribing medication, and some of them actually do talk therapy, I believe. psychologists are specialized in talk therapies and some other additional therapies, right? And PCP is just a general doctor who can recognize the symptoms and also prescribe the medication. Am I right?
Yeah, I mean, mostly, if somebody is not feeling well, they don't necessarily know, oh, I'm clinically depressed. They'll go to their doctor, right? And they'll say, hey, doctor, I'm not doing well. And then they'll describe their symptoms. Now, unfortunately, nowadays, a lot of people just kind of step in the other person's work, which I don't think it's a best practice. I do think that primary care doctors could prescribe the first line of antidepressants, which is usually the SSRIs, the selective serotonin reuptake inhibitors. But really, for more complex cases, they should refer out to psychiatrists or psychiatric nurse practitioners who are trained to work with medicament treatment. So, because of how many medications there are, because of how complex that field is, psychiatrists have really stepped away from doing talk therapy. That was more in like Freudian time. Now we, as clinical psychologists, counselors, even licensed clinical social workers, we are the ones who do talk therapy, with the distinction that we as clinical psychologists can also do what we call psychological evaluations. So like if you're really unsure, if you're depressed, or if your doctor is unsure if it's like unipolar depression or bipolar depression, or maybe dysthymic disorder, which is like a persistent depressive disorder, these are all kind of similar but very different too. Then we can do what's called psychological evaluation, and we can evaluate what is it that your diagnosis is and treat you accordingly, obviously.
Okay. For more severe cases, let's say if someone is suicidal or just have an extremely bad day and it's on the edge, is there any crisis line? Is there any additional help we would like to share with others in case they got into that situation or someone else, their dear friend or whoever needs assistance?
Yes. So unfortunately, with the current government, they're kind of shutting off funding for a crisis line. So what my number one suggestion is for anybody experiencing like suicidal crisis, just go to your emergency room, go to your nearest emergency room. Emergency rooms are not just for medical emergencies. Go there, tell them what's happening, what you're experiencing. Most emergency rooms have crisis workers. So that is like your number one step. Or if you're unable to go, just call 911. I mean, saving your life is priority.
This is a great advice. This is actually really helpful. Personally, I didn't know that 911 and ER are handling stuff like that.
Yeah, sure.
That's very good. Okay, so a little bit about talk therapy. I found out that there's actually many versions of talk therapy, right? And when we talk about depression and anxiety, what kind of talk therapies actually goes along them?
Yeah. So with that, there are many schools of talk therapy, right? And it really depends on, again, the patient. I know that's like not the like most preferred answer, but it's really the truth. Also, I mean, every clinician has their own like approach, I guess. But if I, for example, change my approach or modify it based on the patient. So there are some patients that like a more directive approach.
So it's dynamic, right?
Yes.
Okay.
Yes.
Okay.
Yeah. And actually, all the research about the effectiveness of psychotherapy shows the same thing, which is that the modality you use is not as important as the client-patient relationship as far as effectiveness of treatment, meaning that if using CBT can be equally as effective as using, I don't know, person-centered approach or psychoanalysis, as long as the rapport is there, as long as the relationship between client and patient is effective.
The most common talk therapy, which I experience with the patients I'm seeing, is cognitive behavioral therapy. Let's talk a little bit about that. How many times is expected, and it should be, according to your experience, that one patient needs, let's say per week or per month, or for how long period will take for meaningful results?
Well, we usually do therapy once a week. So that's usual, and that's what most insurances will cover.
Mhm.
If you want to see somebody more than once a week, you have to prove that there is medical necessity for that. So we usually don't do that unless, again, there is necessity. And with CBT, within the first 8 to 16 weeks,
Mhm.
people can expect to see significant improvement of symptoms, even more so with the addition of additional therapies such as TMS.
Okay, that's one of the reasons we are here, and we
Hmm.
won't come to that topic. I just wonder, for those patients who are coming to talk therapy, what is their challenge to stay motivated to come every week, like once a week? What is their motivation, and do you see that retention is pretty good? Because when I compare it to TMS therapies, one of the biggest challenges is commitment.
Hmm.
You need to come every day, so it's a big thing. You need to
Hmm.
drive. You need to continue with your regular life. So it is a challenge. Is that the same thing with talk therapy?
Well, I mean, it's different than it's once a week, right?
Hmm.
But I think what's common here, what could be a stomping place for both TMS and talk therapy is that people want immediate results. And so what happens is they, let's say, come to TMS for 1 week or 2 weeks, and they don't see like immediate, like, oh, I'm happy-go-lucky, I'm a new person, and they're like, oh, this is not working. Even though they don't understand that it might take a little bit longer, and especially for long-term results. So same thing for talk therapy. I feel like that people who don't end up coming back or who end up,
Great.
leaving, are people who are impatient to
Hmm.
see the change. For us, for me, what I have also seen is that the more experience that I've had, the
Hmm.
more I was able to retain patients. So it does, I think, depend on the clinician's skill. But for the TMS, I don't think that would be the case. But for us, it does depend. But I think, like I said, the biggest key factor is that seeing positive change is motivating factor for them to come back.
Oh, of course, it's logical, right? If you
Yeah.
see that something is helping. Well, um, in first episode we had Dr. Adele Murray, who is a TMS expert, and what we figured out is that changing the mindset and the lifestyle, it's that's something which patient has to do, no matter what kind of therapy they're doing, so that they will have the long-lasting results. Okay, so this brings us to something we're working on a TMS protocol. Actually, it's not TMS. It's going to be protocol which will follow what you need to do before TMS therapy, during TMS therapy, and after TMS therapy. That is how we're planning to change the mindset of the patient and have much longer results.
Hmm.
Okay, so you and I, we did share a couple of patients, and I want to hear your objective opinion about TMS. And so far, what you have seen and heard from your patients.
Sure. So, just going back a step, I do agree that a whole mindset, a whole person needs to change in order to experience any kind of positive change with talk therapy, with TMS, with anything, because we are one whole, right? We are a gestalt. We're not two separate entities. Our minds are not separate from our bodies. So we need to make some changes, even in eating habits, sleeping habits, working out, water intake, whatnot. So all of that needs to be addressed. So I'm really excited to hear that there is going to be a protocol like that, supplementation, I believe, and things like that.
Definitely, we realize we need that because right now we have about 15% non-responders. We want to change that,
Mhm.
and I'm sure that patients who does respond, they will have the benefits lasting much longer, and the one which didn't respond have greater chance to
Yeah,
respond.
I agree. And then as far as like you asked me about the experience with
Mhm.
the TMS, yes, I really think that TMS has been like a holy grail for me when I have patients who are highly depressed or unmotivated, or they just don't have the strength to start treatment, to start talking to me, to start implementing what we talk about in day-to-day life. So I can talk and we can discuss whatever, but they just don't do it because they're too depressed. So it would be like, like if a patient was a car, TMS will start the engine and then we would drive it, right? Patient, I will
So it's a
drive it.
kickstart, right?
It's a kickstart, yes.
Okay.
So that's what it's mostly working for. And then obviously kind of maintaining that balance. But yeah, patients who are highly depressed or anxious are not too receptive to talk therapy. I mean, there is obviously a fact, but there has to be something that will help push them.
To push them additionally,
Yes,
right?
additionally, yeah.
And what now when you're saying that there's a certain TMS protocols which are FDA approved, it's called SAINT protocol. We talk a lot about that. It's very aggressive type of TMS. It's basically delivered in 5 days, 10 sessions a day. We were thinking about this if patient is suicidal, so to get faster results, this would be one of the options. Like you just said, the great kickstart for them, and then when they're in a better position, let's embrace them. Let give them talk therapy. Let give them some other therapies to keep them last longer without the symptoms. One of the main reasons why this channel exists, is we always wonder why talk therapy and TMS therapy is not the first choice of treatment for mental health. It seems that the easiest start is medication. So when you first go to PCP or psychiatrist, usually how it goes, they get a medication. They try many different medications. I don't think that that's a right path. That's my personal opinion. I believe that we should always start with something which causes less side effects and it's not chemical. And that talk therapy goes with that, and also TMS therapy. I'm trying to raise the awareness of TMS therapy, how it works and how people can benefit. Unfortunately, this is also related to insurance requirements. So to be TMS to be covered by insurance, it requires 2 to even 4 trials of medication and trial of talk therapy. And then you are basically diagnosed with treatment-resistant major depression, and then you qualify for TMS. This is something I would really, really like to change, because I believe that TMS can do a lot for patients even without trying medication. Medication, to my opinion, should be maybe even the third options. What is your opinion about that?
Well, generally speaking, thankfully, I do see a great movement as far as like psychiatric treatment and conjunction with psychotherapy. So we do see a great movement in having more psychiatrists not even wanting to treat people unless they're in psychotherapy. So that is the good part.
Yes.
Now, as far as TMS and versus medication, I do think that it's better to try something that is not as invasive and not. From my knowledge, TMS doesn't really have a lot of side effects, if any. Whereas some medication can have significant side effects, including like gastrointestinal side effects, and obviously changing your brain's biochemistry. Which just to give a disclaimer, I'm not against medication by any means.
Me neither.
But I do see where you're coming from. I see what you're saying, that something not as invasive should be tried first. Now, without getting too much into politics or bureaucracy, I do think that it probably does have to do with the cost, right? Of it, just like everything else. I mean, I know this is not the topic, but for many people, insurance will not pay for like things like Ozempic or things like that until they become diabetic. So that's what it is. Like same thing for here. Instead of them paying for TMS treatment or similar treatment before you're treatment resistant. They wait for you to become treatment resistant, and then they will let you try it. So
the problem is even we did the calculations because we know that there is a math behind it. So if we look at TMS versus medication in expense to the insurance, actually, if we're looking at a long time or the big picture, I believe the TMS is actually less expensive for them. First of all, what's happening is they're getting one or two SSRIs or whichever mood regulating medication. The problem is that it's compounding in their body over the time. The dosages increase. You become dependent on medication. So you never actually treat the core of the problem. You treat the symptoms, and that's the whole topic, right? Everybody talks about it. This is what's happening. I really hope that things won't change, and who knows? Maybe. But the whole thing is, Matt, it's not that obvious. So TMS therapy is actually it's outperforms. There's a research paper, I can even put it in the description, and for this episode, which says that proves that TMS therapy outperforms medication in any possible mental health state. Now, again, I am not against that. That's medications are necessary. That's fine. I just wouldn't place them in the first place. I would like to thank you for your support and dedicating your time, coming to us and talking with us. Maybe, who knows, we'll share more patients and have more experience, more stuff to share. There is EMDR, there is a bunch of other things coming, good stuff. And hopefully medication will just drop from the first place. At least that's going to be a goal. Thank you so much again.
absolutely.